Hello, my name is Adam Slayton, and today I'm going to be talking about clinical practice and as well as some of the current research regarding West Nile virus. Now, West Nile virus was originally isolated from a woman in Uganda in 1937. Since then, it's expanded globally and is now present in all continents except for Antarctica. Genetically, throughout its history, the virus has mutated and split into several different lineages, two of which are actually the ones that cause pathologies in humans and in mammals, and are therefore the ones we're most concerned about in terms of medical practice. West Nile virus requires an insect vector in order to be transmitted. More specifically, mosquitoes in the genus Culex are responsible for transmitting West Nile viruses. Various species of birds actually serve as the reservoir host for the virus, and so as the virus moves around and is transmitted within bird populations, mosquitoes that bite an infected bird and then bite a human can actually allow for that virus to spill over into the human population. Now, we as humans are actually dead-end hosts, meaning that the virus will never build up enough levels to actually be transmitted from a human to another human, but we still are at risk from being bitten by mosquitoes that have bitten an infected bird. Viral transmission typically is seasonal and usually corresponds with some of the warmer months of the year, which are when mosquitoes are at their highest abundance. But viral transmission can also depend on things like climate and weather, as well as things like activity patterns of birds and human populations as well. Now, as I mentioned earlier, the virus is present in all continents except for Africa, and it's definitely here in the United States. It was introduced in 1999 to the Americas. This figure here illustrates some of the concentrated areas where there was reported cases of neuroinvasive West Nile virus, with the darker regions indicating states where there were the highest numbers of those cases. There are various ways of tracking the virus and studying the transmission of the virus, one of which is looking at reported cases and actually going out and testing the blood of people who live in areas with high viral transmission. Researchers also test birds that are found dead. So when birds are literally falling out of the sky, researchers will see if those birds are succumbing to the virus, and that's another way of tracking the changes in the epidemiology of the virus. Mosquito surveillance programs are also very important. Here at VSU, we have a mosquito surveillance program where we go out and we collect mosquitoes from outside. We bring them back to the lab and we test them for various viruses to see where the transmission is the highest and what viruses are being spread, West Nile being one of them. Now, West Nile virus is an enveloped virus with a plus-sense single strand of RNA serving as its genome. This figure here illustrates how such a virus replicates within a cell. Now, initially, after a human is bitten by a mosquito, the virus will begin to replicate within the keratinocytes just below the site of the bite. But it'll also infect things like Langerhans cells and neutrophils, which can then disseminate to the lymph nodes and then allow the virus to disseminate in the blood. Now, when this happens, peripheral tissues can start to be infected by the virus. Things like spleen, liver, kidneys, and these are usually what lead to the initial symptoms, the more mild symptoms associated with West Nile virus. Our immune systems are usually pretty good at taking care of West Nile virus. As I mentioned earlier, the virus will never build up enough numbers to be transmitted from a human to another human, and that's because typically our immune system can fight it off. Our macrophages are really well adept at presenting West Nile virus antigen to T cells, as well as promoting compounds that stop viral replication within cells. However, West Nile virus has some tricks up its sleeve and is actually good at getting around our immune system sometimes. One of the non-structural proteins that its genome codes for actually interferes with the interferon signaling pathway. So whereas interferon would typically degrade infected cells and virions, that process can be halted because of some of the proteins produced by West Nile virus. Another protein actually interferes with the apoptotic cycle, and so a cell that would normally die and the virus would no longer be able to replicate inside of it, the virus actually halts the death of that cell so that it can continue to use the cell as a host for replication. Now, in extreme circumstances, about 5 days post-infection, sometimes the virus can find itself disseminated into the central nervous system. Now, the mechanism by which the virus finds its way into the central nervous system is still unclear, but there are a few different hypotheses regarding how it does this. One of those hypotheses, which actually has the most evidence-based research behind it, is that the virus finds a way to penetrate the blood-brain barrier. It can do this in a couple of different ways. One, during the immune response, the body produces proteins that aren't very good for cells. It's part of the immune response and how cells can die as a result of it. Those proteins can actually weaken the integrity of the epithelial lining of the blood-brain barrier, allowing the virus to kind of slip through. Viruses can also infect leukocytes, which then can travel to the blood-brain barrier, and they produce these compounds called cellular adhesion molecules, which then again weaken the integrity of the epithelial lining of the blood-brain barrier, and that's another way that the virus can reach the central nervous system. Another hypothesis of how it gets disseminated into our central nervous system is by a retrograde axonal transport system, whereby they will actually infect peripheral neurons and then travel up the axon to our spine. At any case, no matter how the virus is infecting the cells within our bodies are going to be producing an immune response in response to that viral infection. And that immune response is usually what causes some of the more common symptoms of West Nile virus. Things like a mild fever, inflammation and pain in the joints, things like that, diarrhea, vomiting, rash are all signs and symptoms of West Nile virus that can result from an immune response after an initial infection with the virus. Now, in more severe circumstances, the immune response in the central nervous system can invoke a higher fever, can cause things like neck stiffness and neuronal death within the brain, which then creates a vicious cycle where more neurons die, releasing more toxic molecules and a worse immune response. And once those things start to occur within the brain, that's when you get things like meningitis and encephalitis, and some of the really severe neuronal issues like coma, tremors, convulsions, blindness, paralysis, and in the worst case scenario, death. Now, I may have mentioned this earlier, but 80% of the individuals who are bitten by an infected mosquito don't actually show symptoms. Most of the time, they're asymptomatic. Only about 20% actually end up showing symptoms, and of those, less than 1% actually develop a neuroinvasive stage of West Nile virus. So the most severe form of the virus is not the most common by any means. In the US, after it was introduced in 1999, we're kind of starting to see a decline in the number of reported cases of West Nile virus. And then for whatever reason, in 2012, we really had an exceptionally high number of cases of West Nile virus. But ever since then, up to now, there has been a steady decline in West Nile cases that are being reported. This leads us to our case study, which is actually pretty cool. I was able to get in touch with someone so that I could ask that patient about their experience. In June of 2007, a 24-year-old Caucasian male from Florida presented with a headache that he said had been occurring for a couple of days, a runny nose, joint pain, as well as an overall feeling of lethargy. There was no history of serious medical condition, no pre-existing medical conditions that could have explained his symptoms. After a physical examination and after his vitals were taken, there was nothing to really lead in any direction other than that he had a temperature of 99.4. Nothing by any means to get worried about. Now, after a brief history was taken, it was discovered that the man was a frequent outdoorsman and that he spent a lot of time outside. The physician diagnosed him with seasonal allergies and prescribed him some antihistamines to kind of clear that up. 2 days later, the patient returned, having developed a new symptom of diarrhea, and also saying that the headache had not gone away but had gotten worse, and that the arthritis in his joints had gotten much worse as well. At this point, his fever had risen to 101. A little bit more digging by the physician revealed that the man was actually employed by a local health department in a mosquito surveillance program where he was actually frequently outside in areas with high numbers of mosquitoes. The physician then took some blood and sent it off for testing and prescribed medications for the joint pain and for the anti-diarrhea, and for the diarrhea, excuse me. That blood came back positive for the presence of West Nile virus IgM antibody, confirming that it was a West Nile virus infection. 2 weeks later, the patient was fine, and the infection had run its course with no serious complications. Now, when we look at how this played out in the patient versus what we typically see in a clinical case of West Nile virus, we'll notice that most of his symptoms were classic signs of West Nile virus. He had the high fever, the joint pain, diarrhea, headache, all things that are invoked by an immune response after being infected by the virus. He may not have had some of the other common symptoms, such as vomiting, body aches, and even a rash. And the runny nose itself is not indicative of West Nile virus. It may or may not have been caused by the virus, but it's certainly not something we would typically see. The method for testing and diagnosing it, in the end though, a blood test is what you most commonly see, and treating the symptoms is really the only efficient way of treating West Nile. There is no specific treatment for the virus itself. I think some of the key takeaways from this case study, one of course is that the initial diagnosis was incorrect. And I think part of the reason for that is that the initial history was incomplete. Clearly the man had been exposed to high numbers of mosquitoes in an area where West Nile virus was being transmitted, but that was not known until after some of the more severe symptoms had kind of manifested. And I think that just speaks to making sure that you have a complete history, not just with cases of West Nile, but in any case where you're trying to figure out what the disease is. In contacting the patient, they also spoke of a lack of concern on the doctor's part, as well as feeling rushed when they were consulting with the physician. I think sometimes you have to take complaints like that with a grain of salt, but it speaks to the fact that when we're conducting ourselves in front of patients, we have to be aware of how we're conducting it and the way we're behaving in front of patients, so as to avoid certain perceptions that might not be favorable, things like apathy, and things like that, especially in a case where the diagnosis might actually be incorrect. In terms of how we can apply this to future practice, I think something that's important is recognizing that the epidemiology of a disease is fluid and it can actually change pretty rapidly. This figure illustrates the spread of West Nile virus in the United States from 1999, when it was first introduced, all the way to 2003, just 4 years later. By 2003, over half the United States had been reporting cases of West Nile virus, and that's much more than we had in 1999, when the disease wasn't even present yet. So I think in early 2000s, it probably would have been easy to overlook a diagnosis of West Nile, especially when it's June, it's someone who's outside all the time, they have a runny nose. A logical conclusion might be seasonal allergies, but understanding that what a disease that might not have been present beforehand can definitely be present now, because the epidemiology does change. Other things to consider is that client education is perhaps the best way to make sure that people are informed about what they're doing and actively preventing the spread of a disease. Letting patients know that when you go outside in areas that have mosquitoes in the warm months, put on insect repellent and wear long sleeves and long pants to prevent getting bitten by an infectious mosquito. I preface that by saying that there are certain realities we also have to keep in mind. It might not be realistic to expect a patient to wear long sleeves and long pants during the hottest months of the year. The other thing you have to realize is that even a patient who frequently worked with mosquitoes at a West Nile virus surveillance program didn't think to mention that during the initial history. And so the clients we see are not going to be medical experts. That's why they're coming to us. And in all cases, we should consider not just the symptoms, but the context of the disease when we're coming up with a diagnosis. In summary, West Nile virus was once an emerging disease, but it's definitely well established within the United States. It's typically asymptomatic, but it can result in several flu-like symptoms that may not necessarily pinpoint what the disease is. And again, the context of the disease may sometimes be more important in diagnosing West Nile than the actual symptoms themselves. Even though it doesn't always cause severe symptoms, West Nile virus can be fatal when it reaches a neuroinvasive stage that can actually penetrate your central nervous system and cause things like encephalitis and meningitis. At any rate, prevention is the best way to make sure that you don't end up with a lethal case of West Nile virus. Things like making sure you prevent the initial mosquito bite, because there are no vaccines against the virus and there are no real treatments for it. All you can do is manage the symptoms until the infection has run its course. Thank you.